Welcome to Rehab Remix Reimagining Boundaries, the podcast that explores the future of orthopedic rehab within the construct of clinical innovation and connected health. I'm Rohit Nayak, co-founder of BandConnect, your host for the segment. Our goals through our discussions is to energize all of you to play a role in helping us address the many challenges we all face in PT and orthopedic rehab as patients, clinicians, or clinic leaders. Today, it is my privilege to introduce Dr. Charles Thigpen, or Chuck, as the world knows him. As a brief introduction, Chuck is a Chief Clinical and Strategy Officer at ATI Physical Therapy. His LinkedIn byline says he's passionate about transforming MSK healthcare. He does that and a lot more in a variety of ways. At ATI, he leads enterprise-wide clinical services, quality improvement, and innovation to advance MSK care delivery. A clinician scientist and a healthcare strategist in all the aspects of that word, Dr. Thigpen integrates evidence-based medicine, digital transformation, and health ecosystem partnerships to expand access and, of course, improve outcomes. In keeping with his research and academic roots, Chuck also holds adjunct appointments with Duke, University of South Carolina, and Clemson University. Along the way, he has authored over 100 peer-reviewed publications in leading orthopedic and sports medicine journals. Beyond all that, he's taking time to talk to us today, so I'm really excited. I could go on, but he is more than qualified to address this goal of transforming MSK healthcare, which makes him an ideal guest for this podcast. Chuck, welcome, and thanks for taking the time to be here.
No, thanks a lot. It's crazy in 30 years what you can learn. So what I heard in that is, man, I've learned a lot in 30 years as a PT and athletic trainer.
I love digging into your background and journey, particularly given your academic and research roots. That's somewhat atypical for a lot of the folks that I've talked to. We'll dig into that a little bit, but let's start a little bit on your journey. You've had multiple roles at ATI for almost 20 years, as I can tell, but you've had prior academic and research roots before you jumped into the industry. Can you talk about that a little bit, about your journey?
No, I'd love to. So I look back, I started as a student athletic trainer, University of Tennessee, Chattanooga in the mid 90s. And really, because like lots of people in therapy and athletic training, I was hurting in the training room. And so I had a couple of big injuries, went to the physical therapist for the first time when I dislocated my shoulder and spent some time. I'm like, oh, I didn't even know you could do this, and became interested in it. And so I think from there, I got out. Man, I didn't know anything. I look back and I graduated in 1996, 30 years this year, graduating PT school. And I'm like, man, I had zero idea what was going on. I didn't even know what I didn't know. And so early in my career, I was just consuming, trying to help, doing the best I could. Was so fortunate to have some really good mentors come along and go, hey, come over here and learn like this, and this is how you get people better. Both modeling from working hard and just being where patients are and just kind of listening and helping folks. And then I went to the University of North Carolina because I'm older and I only have a bachelor's in physical therapy. There wasn't residencies and fellowships weren't a thing yet. So then you would go get your advanced masters. I don't know why it was called an advanced masters. Like, aren't all masters advances anyway? You would go apply to these programs, and they would be some mix of clinical and academic. And so I got my master's at UNC, and it was at the time a really unique program where you could spend some time in athletic training and covering collegiate sports and on the clinical rehab side and then on the research science side. So you got a little bit of each. And that's really opened my eyes to just a whole other way of practicing. There's a team there at the time, Bill Prentice, Dan Hooker, Mark Davis, CB Lean, Sally Mays, like really high level sports medicine clinician scientists that were plugged in with the academic side. So at the time, Kevin Guskowitz, who's now at Michigan State as their president, I think that's what he's called there. But Kevin was there really in the early findings and things that he was discovering, concussion research. Darren Padua, my mentor, was doing early work in ACL prevention. So there's just a really lot of exciting clinical level work, which I saw these individuals practicing at a high level clinically, teaching, and contributing to research. I'm like, I want to do that. And so that led me to my path to get my PhD. I was there longer than most, so I'm pretty overeducated. I'm a slow learner, just way too much in school. And as I came through that, I came to the end and I realized that while being in the lab was cool with about my backgrounds in shoulder biomechanics and fancy and measuring everything to a high degree of precision, I realized that wasn't the gap in clinical care of what we do. And I was trying to take the lab to the clinic, which actually you and I've talked about a little bit with some of the work that you guys are doing. Like a little bit like in my mind, you've actually taken the lab to the clinic. I can actually measure things in the clinic, but I think trying to figure out how to do that. And so I tried that in an academic setting, was really fortunate. University of North Florida was my first job out of my PhD. I was a young faculty member. I had PT students teaching, but I had a chance to build a lab and work with Brooks Rehabilitation to try and bring orthopedic patients to the lab. But what I learned pretty quickly is that, which makes sense now having three kids trying to run around, like I do not have time to go to therapy, get my therapy, and go over here to a lab so you can do some fancy measurement. Like life's busy. And so the lab just wasn't as busy as I would want. And so more and more I realized I needed to be in the clinic. And so I got an opportunity to come to Greenville in 2008. At the time, Dr. Richard Hawkins was here. ProAxis Therapy was a small fledgling therapy company, I think maybe 5 clinics at the time, and came really with a chance to build a clinical research in the clinics. And that's what Dr. Hawkins was interested in. He had done that in Vail. So I was just really fortunate for about 10 years to walk across the hall with, I think, the greatest shoulder surgeon ever, but I'm highly biased. At the same time, Dr. Ellen Shanley came and was working on her PhD, and she's published a ton in injury risk. And so we just had this really interesting clinician scientist in the clinic and a chance to grow and develop. And so what I realized in that time is, oh, well, if I can maybe do some research and publish a little bit, maybe that'll help more people and maybe teach a little bit and have an impact. And I think that's probably became what's the gap in clinical care? And then how can I help more people learn about it to help more people has sort of been the driving pieces for me. And then mid, I guess around 2015, ATI acquired ProAxis. And so now these are the early days of large practices growing. And at the time, I think ATI was the largest with maybe 250 clinics. And then that year, by 16, we were over 400, and now we're over 850. And that was really some of the first of just really growing into these large platforms. And what I realized is there was an opportunity by collecting outcomes, which we needed for payment. And I was thankful our leaders and ownership was committed to doing that. We began collecting outcomes. And so I was able to kind of lean in with the team, and we continued to collect outcomes. We standardized what we were collecting. I'm like, aha, this is like a research project. And I've gotten simpler and simpler over time with what we're collecting. But we now have the ATI patient registry, over 4 million episodes of care, over 7 million patients there that I have clinical data on and all the things. So I think, but it was all around this idea of what do I not know? What do we not know to get patients better and do that? So I think as my roles have come along in different places, it's really been around how do we help more people get better? And then how do I equip clinicians to do that? So that's what's exciting where I sit today. I get to kind of sit in those two rounds. It's just a little broader perspective than maybe I had in 1996.
That's awesome. My background, I was in engineering, started getting a little bit into R&D, and very quickly I thought about how can I take what I'm doing and apply it to industry. But I still have those research roots somewhere, and I think you've had a great sandbox, if I can call it that,
That's right.
to actually take your background and apply it in actual practice care. The fact that you created a registry by itself is phenomenal. Congratulations.
Look, I think, as you know, with anything like that, it's a little bit of timing, right place, right time. And then Adam Lutz is with us, PhD, and he was actually funny. He was one of my he was one of my PT students. He
Yeah.
went and practiced for a while, came back and got his PhD, and now he still works with us, which I'm thankful for. But well, wait a minute, like we have all this data. If we make it a registry and set it apart separately, we can protect patients, do all the right things, and we can learn a lot. So we've been really lucky to work with some other individuals, University of South Carolina and Duke University, and some other folks that have much better expertise in how to leverage and do that. And I'm so fortunate to be able to help create that, but it's really right place, right time.
Yep, that's phenomenal. As you know, at Band Connect, we've been focusing on providing technology for a blended care model, right? That sort of leverages the in-clinic experience and drives the virtual experience at home and brings that connectivity together. You do a lot of work around care delivery models. And so I thought I'd just jump in right there to get your perspective on the many areas that you're looking at from a care delivery standpoint.
No, we've had some really good discussions. I chuckle a little bit. I'm thankful I had a good marketing team early in COVID when we branded our virtual platform ATI Connect, because it seems to be a good idea. I think when I think about evolving care delivery, I probably think about it in three different ways. And I think one is just how we work. And I think one of the things over time, it's fascinating, right? 30 years is not a minute. PT is not that different than when I started.
Yep.
I mean, it's really not. Like you kind of schedule appointments in a similar way. Everybody's got their preference. But PTs essentially do the same thing we did there. And I think then the question becomes it's probably more driven by your setting and who mentored you and then who your patient population is. It's what you think it is, as opposed to this is the best way to have clinical workflows to deliver care. And so I
Yep.
think that's probably, as I begin to understand things like industrial engineering, right? There's whole professions that's all they do. And I think as
Yeah.
we have a separate part of our business, not our PT clinics, that are out and do it's called ATI Worksite Solutions on site in industry. But like all of these industries, pharmacy, for example, have really highly skilled industrial engineers that go and they count everything that happens, right, and create an activity log and go, wait a minute, we have the wrong resource at this time. And if we fix this problem here, we can deliver,
Right.
in that case, a pharmacy process more efficiently. And so I'm like, wait a minute, that probably applies to PT. I think about early with ProAxis. Clemson has an industrial engineering program. It's a big engineering land grant school. And so we had an industrial engineer come and count steps. We had a huge clinic. I think it's 12 to 15,000 square feet. And I forget the exact amount, but essentially it was way too far to go to the closet at the front of the clinic to get supplies. And they were like, if you just put baskets of supplies under all the tables and plants in the back of the clinics, you could save yourself. And I don't remember, it was hours a day though of your staff walking to the front and to the back that you would never have known unless you evaluated how you're actually doing the work. So I think it's one of the lenses. It's not actually changing what you're actually doing, but just how you're doing it. Is there a better way to do it? And I think sometimes we get fixated on, well, I was taught, or we've always, instead of going, wait a minute, what are we actually doing? What's our goal? And
Yeah.
for me, the common theme you'll hear from me across all these, it's not my preference. It's, am I committed to getting patients better?
Right.
And what does it take to get the patient better? And you'll hear this on each. So I think the first is how are we delivering care? What's the process of care? Is probably the first thing I think about. The other two pieces really are, if I think about, I got a bachelor's. Not long after I finished my bachelor's, everybody was getting a master's in PT, and then not long after that didn't last, everybody has a DPT, right? And so we're a solid 20 years now into being a doctoring profession, but you go back, we still do the same thing.
Right.
And there's a lot of reasons for that, how we're reimbursed and paid. But I think about early physical therapy evolved out of really almost being a technician that a physician would tell you what to do. And now we bristle at
Yeah.
that. I shouldn't be told what to do. You're right, you should. And you shouldn't operate like that. So I
Right.
think thinking about top of license practice, what does that really mean? And I think it's back to the how do you work. industrial engineers define what are only the tasks and responsibilities that a certain role can do, and that's all they do because that's the highest return, within a manufacturing or process that's very linear. I don't know that we think about clinical care that way. And so I think when you think about what can be delegated becomes really important, what should be delegated. And then even more, while we've developed as a doctoring profession, we haven't really taught people how to delegate clinical care, which is really interesting, right? Because it's a different thing in PT for me to tell you, hey, Rohit, here's a group of exercises that we're going to do with Miss Jones, and here's what I want you to do. And so I think that's where there's a lot of opportunity that probably leads to the last is if we're committed to get people better, we're committed to practicing at the time since working, then how do I leverage technology to do that? And I think a lot of times, and I really appreciate talking to you, you come with a clinical mindset of how do I solve a clinical problem, not that, hey, I have great tech that can fix
Right.
everything. There's plenty of that out there.
Right.
There's even whole companies that have built recent IPOs that I won't mention that are great tech companies but have zero clinical
Right.
grounding. And from my opinion, that likely won't succeed because it's anchored on tech and not anchored on clinical care. And so then in the technology span, I'm looking for what are ways we can bring technology, right? Whether a sensor integrated with bands, virtual has been a lot of our piece over the last 5 years of really building a fully integrated hybrid platform. And then everybody's favorite topic over the last 18 months, AI, and how are you using it? You and I are talking just for the how you're able to produce a podcast is just ridiculously easy now because people deployed AI and large
Right.
language models. So I think, and I don't know what the next tech thing will be on the clinical care, but looking at those anchored around how do I get patients better? And then I think given the workforce shortage that we have in PT, how do I get more patients better? That demand's not really an issue in most
Yes.
PT clinics. It's
Yeah. I
actually
haven't seen one.
efficient
Yeah.
to see. And so how can I do that in a better way?
Yeah. You covered a lot of ground here with your topics, and I'm going to pick on one at a time. So,
Yes.
starting with the model piece itself, and one of the things that bothers me is when people talk about what is the practice model of the future. And I think it probably bothers you as well, because just listening to you and talking about those incremental ways of how we're doing what we're doing and making those minor changes to drive a better experience in terms of the clinician, the patient, and ultimately delivering better outcomes. What I think, and this is my bias, I think a good way to look at it is the way that you referenced it, is to how can we redefine or reimagine the possibilities around care as we deliver it today, so that it's not just fixated just on in-person care or virtual care, but a blend, right? That talks about what is most optimum, what can be delegated to whom, just as you said, and moving that forward. I think you resonate with that particular approach, don't you?
No, for sure. I think so much there, richness in what you laid out. I think just understanding what are we anchoring around. And to me, it's how can I imagine people getting, and I think what's the reality is in the hybrid virtual world, COVID forced us to think differently. It just took, and it's one of the interesting things, and it's actually a trend if you look over different innovation factors. Oftentimes, external factors drive it, and something like the pandemic gave us the opportunity to do that. And I think it surged, it fell off, but now I think you're starting to see a few places emerge that actually learned something and applied it as opposed to just going back. Because right, the world will never be the same as it
Right.
was pre. We all know this. Question is, how can we imagine? So I think what's interesting is how do you create those little pockets of testing and learning to just make that how we think, right? That we're just always operating. I think it's such a challenge to just do what we do. And all of a sudden you realize, man, I've been doing the same thing for 10 years. And I literally the same thing every day. I got the same coffee store, get the same bagel, got the same place, get
Yeah.
the same thing. And I think that's for me what makes it, I like to learn and do something different is sort of drawn me to this anchoring. But I think being centered around probably two things. One is I believe strongly that physical therapy matters in helping patients get better. I know that to be true. And it's anchored around getting patients better. It's not around how I want to. And you can, there's some push and take there. And I think sometimes we get anchored around what I want and we confuse my preferences and my background, and it limits our imagination of how I might get patients better.
Yeah. Yeah. Yeah, no, I resonate with a lot of what you just said here. I almost feel as if we talk about reimbursement, you mentioned it briefly. We talk about PT burnout. I've become a big flag carrier for PT clinicians, and people keep telling us this is a really hard market for you to be at. But the more time I spend working with clinics, looking at these clinicians, I see them so conscientious, right? Clinically, in terms of what they're doing, in terms of how they're managing their patients. But the circumstances, in my opinion, are not in their favor, right? Yeah, but it's so hard. Things are so transactional, right? Which is why I sort of go back to this whole notion of there's a lot of conversation around reimbursement, but I feel as it's back to one of the things that you said, right? We should be tooting our horns even louder about the value that we provide in general, right? So that we're not talking necessarily just about visits, because I don't believe that by itself is an anchor of how things work. So
No, that it's such a good. So I think a couple of things. One is PTs measure the quality of their care and how much time did I spend with a patient,
right,
and do I know your kids' names, and what your goals are, and did I meet your larger emotional need that you had coming to therapy,
right,
which is real and it's huge. Look, there's bodies
right,
that look. One of the reasons PT works is because I know you and I know what makes you tick, and I can get you to do things you don't want to do that are hard for that. And insurance on the other side in the reimbursement world just counts visits in units and dollars.
yeah,
And so the challenge is the gap is the actual value is somewhere in between those two things. It's actually did you reach your goals? Did I meet your expectations? Did I get you better? Right? Can you do more than you did before? And did I do it in a sustainable way? And I think we like to uncouple those two things and make them almost competing. And so you end up with these two islands, right? You've got an island of PT on one extreme that's like every patient needs only one on one care
right,
for however much time. And on the other side, you've got payers that are like, no, 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 I'm only paying you for 25 minutes of your time. So it creates this dichotomous, and neither one are true,
right.
right? Anytime you say always or never right wrong, is places. So I think then the challenge is what is the common ground? And I think for me, that's why I try to put things in context. Is it getting the patient better? Yes or no? And look, there's ways to measure, and if you're not measuring if patients are getting better, you probably don't know. I don't know that I know for a fact we don't get every patient better because not every patient gets better with PT. But what I do know is I know at a clinician, clinic, region, district, kind of as you're organized across the country, I've got a pretty strong sense, a very strong sense with objective number how patients are getting. So now I have a common ground for value that then if I put a denominator of money on the other side, reimbursement, now I can actually quantify value in a real number and not just some abstract ability to tell a narrative. And I think that for me has been a driving force of how do I create better reimbursement for the services therapists deliver so we're actually valued for it. Because I think a lot of people like to go out and scream and create social media and get all fired up about it, or a lot just leave the profession. And so I think for me is trying to look for ways to put real numbers in aggregate together to demonstrate the value of PT.
Yeah, that's why I love about your background and what brings you here. and anchoring around patient outcomes is, in my opinion, the single most preferred way to look at all this, because it encompasses everything that follows, right? So I think that's how I feel, and that's what I was trying to say. Just focusing just on the in-clinic reimbursement by itself, although it's a big factor. That's why I think you have a really tough job, right? Because you're trying to mix these concepts together
I thought it
and
was fun.
it's fun. I'm sure it is fun, which is why people like you and me are doing what we're doing, respectively, right?
That's
Is
right.
if it was easy, then everybody would do it. So on that same point, right? So some of my background include value-based care in other segments, in other industries. So I've always been knocking on the door, trying to understand. I was surprised when there was little or none of that in the PT spectrum, at least the ones that I've encountered. And I know I'm still early. I was talking to one a payer a couple of years back, and what he said was very true, but it also surprised me. He said, "We don't believe that the PT has a predictable influence on outcome on a patient's outcome, which is why we'll always be slow on bundled or value-based care orientations as it relates to PT itself." Now, VBC has a lot of pros and cons, so I'm not a qualified PT. And I can say that I have a lot to contribute to that particular scenario as well. But overall, I believe as an industry, and I think you were alluding to this, if we all shout from the rooftops of the value in a quantified manner, the value that we're providing in terms of outcomes, I think some of the ingredients and the types of conversations that we're having will change.
Now, look, I think we like to shout from the rooftops. We don't have any substance behind what we are sometimes.
Right.
And so I think one of the things I appreciate, there's a industry group, a trade organization called TQI, the Alliance for Physical Therapy, Quality and Innovation, that started around 2014, 2015. But really, that's really been one of the areas that we've leaned in together and aggregated data together to create risk adjusted measures for PT and worked across groups to do that. And I think create sort of a standard way to measure quality. We worked with CMS, they're now approved measures, and they're actually one of the common measures that have used. And it's not just one group, it's Intermountain, WebPT,
Hmm.
Limber,
Hmm.
other APTQI platforms and partners have contributed data together to kind of create these really cool measures. So I think it's been a really neat experience to see that now an MSK measure set that we can do that. And now there's real data. We can go look, CMS data has data across multiple years now that show if the range in improvement in outcomes. And now you can start to tag costs to that to begin to understand that. And I think having real data to back that up begins to counter that argument that honestly is probably a little archaic. Most insurance companies have
Right.
CMOs or physicians that have never seen PT outside of their residency or maybe their
Right.
specialty, like in
Oh, absolutely.
orthopedics. And so that's on us as a profession to one demonstrate it numerically.
I'll jump right in. What does clinical or care delivery innovation look like for you in physical therapy? From our standpoint, giving clinicians the tools to help them practice manage medicine to the full extent of their education is something that feels compelling, right? And we feel as if we're doing that. But sometimes that is at crossroads with all the operational needs of a practice, of a successful practice. So just curious, you looked at a lot of technologies. How do you see that evolving?
I started to practice. And the areas that I've played in probably the most have been around, my background was in biomechanics and in a biomechanics lab. So in capture, force plates, EMG, biofeedback, those are kind of, when I think about biomechanical, those are kind of the core tools that we tend to use. And in my PhD program, we had our own little lab. We'd go build forge transducers, very simple, because they're
Yeah.
during and away you went. But what I learned quickly is just because I can measure something at an nth degree of specificity didn't necessarily change what happened in the clinic.
Right. Yeah.
Essentially be more efficient in delivering that care. So I think define
Right.
cool tech that's amazing, but then you go, huh, why does this actually matter in the clinic?
That's a topic that we come across every day, right? So how do we continue to get better at what we do, but fit in within the constructs and the constraints of what is considered as today? And we work hard at that. And there's always room to do
Well, and
better, just as you said, right? So yeah.
market pre 2 years ago, they were all industrial grade. You could push, pull, do all great things, but they're $1,500 each. But like actually in a clinic, like how many patients can generate 500 newtons of force? Not many. So right then, actually, the technology you needed to measure was much cheaper. Right, I didn't need a 1,000 kilo force transducer. I just needed a 10 kilo. I mean, a much smaller one, which means they're
Yeah.
cheaper. And so I think,
Right.
and what I think about there is not only what can the technology measure and how precise. And so I think a lot of times engineers, technologists, people who live in the lab think more precision is better, but that's not actually the right question.
Right.
Once you know the problem, what
Right.
degree actually drives a clinical decision? So I'll give you an example. When we were doing jump landing studies, we went to the military academies. I was a doctoral student. Thousands of cadets at military academies jumped on a force plate. We would see how they landed and then look at who got injured. And what we learned in doing that is the actual number degrees of knee flexion and hip flexion, it was probably 10, 15 degrees. If the difference was less than that, it didn't actually change the decision. And so what became interesting then, if you think about that as well as the variability of technology, especially now, right? Like my iPhone is faster than the cameras we use then. I can actually get
Yeah.
reasonable clinical information with an easy clinical video that drives clinical decisions. And so I think balancing that, how precise do we need with technology and where's the value add, allows you to make better clinical decisions. And that's really sort of maybe at the core of when I think about how to enable and help patients make better decisions, which should drive better patient outcomes.
That's music to my ears because I shouldn't be talking too much about Band Connect here, but that's exactly what we did. We wanted to keep things simple, but yes, useful. And we had to make some choices from a design constraint standpoint in terms of how we move forward. We'll talk about that another day.
I don't have a lot of clinics I can spend a lot of time tinkering. I'm trying to find something simple that I can do across 850 clinics that I relatively easy can put in 3,000 clinicians' hands. They're like, oh, that makes sense. I know how to do that, and move on because they're busy. They've got a lot of patients to take care of. They're not necessarily in a position to learn a whole new way to operate. So I think
Yeah.
having relatively simple, impactful pieces that gets the clinician adoption. And then the other side is, what does the patient get out of it? Because it's the funny thing for all these technologies we're trying to implement. I don't have one adoption criteria. I actually have two sets, right? I've got to solve what the patient wants
Of course.
and what the clinician needs to get that adoption. So you end up, we always talk about the technology adoption curve, and they're not the same, right? The pace of adoption for
So
a clinical segment or a patient segment are very different.
We've definitely looked at it that way. What shows up on our patient app, just as a simple example, is entirely different than what we're sharing with our clinicians. And transitioning a little bit, okay? There's a lot of discussion around PT first care, right? And this is specific to the industry. And I'm saying this in the construct of surgeries, right? So a patient goes through physical therapy first, determines if there's any improvement in terms of whatever their condition is. Are they a surgical candidate or not? Or what is their persuasion following that? Uh, but I read more and more about PTs and PT articles talks about, hey, we can do this better than surgery. And I feel as if there's a contradiction there, right? Because PTs work very, very closely with surgeons themselves. And in fact, one of our orthopedic surgery groups, they're a market segment for us as well. They have their own rehab clinics. And they're been forcing us to look at the prehab segment. When they first identify patients, and at least from what they've told us, they didn't particularly care as to what the outcome was, whether it's surgical or otherwise, but they felt that they could use this hybrid technology for that as well. Large topic here, but I just
No,
wanted to get your thought
it's great.
process.
I'm super passionate in this bucket. We actually, 15 years ago this month, I was called to a meeting with one of our large partners and said, we will do less low back pain MRIs. And you're going to help fix it. And here's this program I read in the Wall Street Journal. And that was when I started to learn about early PT or PT first as an option. I think what I've learned in that is I've never done it independent as competitive with surgeons. I've been really blessed that I've had very supportive surgeons. Now, look, we've had to do some education about what a PT can and can't do and how they fit in. And fortunately, most of the surgeons I've worked with in this program had a
Right.
military background. And so they had probably a better expectation of how a PT would function at a high level. And so in that, I think where we've landed is, look, there's very few musculoskeletal conditions that seeing a PT sooner at, to the time of first complaint and disability, it doesn't do better. And there's a lot of reasons behind that, not only the effectiveness of PT, but in most states, we aren't ordering opioids, MRIs, or sending people to surgery, which are cost saving. And typically, we're fairly effective with simple interventions and lifestyle behavior to get people better. So I think that's sort of maybe one bucket. And I think so not building silos, really having, I'm a blocking and tackling guy, just super simple, consistent interventions. And then I think what's so important is having the right surgical partners to escalate to. And so I
Yeah,
think
totally.
having that continuum, and so I think our focus at ATI, where my focus is how do we plug into the healthcare ecosystem in the right spot? I'm not trying to keep all the patients over here and nobody ever sees a surgeon. That's not my role. That's not what a
Right.
patient would expect. What a patient wants to know is if I don't need to see the surgeon, I don't want to see him. But if I do, don't delay me getting there. And it's when I think about some of the technology out in the space today, and all they talk about surgery avoidance, and they might be an IPO that has a that's pretty large. That's
Yeah,
not the game. That will. I don't think that'll
it's
ever
not.
be
Yeah,
effective, right? Because at the end of the day, you're now pitting good care for the patient against your value proposition, as opposed to, I told this to a clinical group of our clinical leaders this morning. I have yet to see when good clinical practice anchored in best evidence isn't good business. I have yet to see it. And so then the question is, you just have to
right.
define the value you're driving. And so for me, early PT isn't a tech issue. It's not, it's really taking care of
Yeah,
the
it's not.
patient. And then look, I think the digital tools, we've been very aggressive in this space, learning and building a national virtual practice. And we've now scaled our hybrid platform nationally, seeing 30% plus of our patients engage in a hybrid program. Patients like it. That's how I consume the world, right? Like it's what I do.
Yeah.
I'm looking for a new car because I have a transmission issue. Guess how I'm doing it? On my phone. I'm not going to the car lot. Like it's how we consume and operate. And so I think that's the balance of opening the doors to PT early, leveraging technology for easier access, because that's what patients are going to do, right? Because that's what meets their needs.
You said it perfectly. It's a lot more nuanced than I typically hear about it. And so really happy to hear that from you. It's not one versus the other. It's about how they blend together for the right
Yeah,
purpose,
for
for the right
sure.
outcome. So, quick note on value-based care. We talked about it during our first session a little bit, but I just wanted to get your perspective on, do you see that
You
happening
know,
anytime soon?
I have
Particularly,
whiplash. I feel like it's coming, and then it never happens. So, we've been, because of my background in outcomes and collecting outcomes, as the MIPS program came along and we developed some stuff. So great, like I'm actually going to get paid for outcomes. The reality is it hasn't materialized in the way that's what I would say the reimbursement and financial model matches the effort it takes to do it. I think we're at a spot though with all the if you look at all the need to reduce the cost of Medicare alone, just as that is a single entity, I think we're coming to a forcing function that there's going to have to be a different way. And independent of my views on administration, putting politics aside on all of that, I do think what you see is a pretty aggressive way to change the way people are being paid. And CMS has continued that from the ACA work into now of the new AHEAD and TEAMS model. They're going to force providers to be paid differently. So I think the question for PT is it's not exactly clear how we fit into that. We clearly can drive cost savings. A lot of physicians who unfortunately sit at the top of some of the CMS pieces don't fully understand that. So APTQI, I know
right.
APTA, the orthopedic section, APTA, and the private practice section, all are working together to really clearly articulate the high quality, low cost care that PT provides and ensuring we're getting paid for that. So I would say I know it's coming. I don't think it's tomorrow, but I do see some things
Right.
happening that I think it's right on the horizon. And it's not because everybody's like, oh, we have to do value based care. It's going to be the forcing function of the cost. And on the other side of the headwinds that the PT profession has around reimbursement are going to kind of crash up, that there's going to have to be a different way to get paid and deliver care evolve.
Because I see some of the visit-based reimbursement driving behavior on all sides, the payers, the consumers, and the clinicians, right? It's a very high-level perspective, but I feel as if some change over there would help us all catalyze towards things that we all want
That's
to
right.
do, clearly. So, yeah. And so I'm going to try and wrap up here,
Okay.
rapid fire questions, just keep things interesting a little bit. A trend in rehab that excites you.
I'm going to go with the virtual and RTM pieces. I think integrating this technology into the care model and care plan, I think is going to be transformative in time. And so I'm really excited to see what we learn about how to take care of patients and what that impact is.
Awesome. I like that one. A trend that worries you.
People leaving the profession. We have to find a way to compensate fairly for the value being driven and balance with the cost of education and do that. If we don't do that, it is maybe is the singular risk to the profession is just creating long-term PTs. I've been in it 30 years. I love the profession, but there's not enough
Yeah.
people that stay with it that long.
Yeah. So that sort of leads me to where I think I will end then. So what's the one piece of advice that you would give to wannabe clinicians, patients, or even students who want to push this field forward?
I think for me, it is, I'm a lifelong learner. Some say a dork. But I
Hmm.
think finding I've failed plenty. I can tell you a long list of things that don't work, and I think just understanding. I was really fortunate early that that wasn't seen as the end of the world. Hey, you learned something. What do you do different? And so I hear people talk about a growth mindset now. I don't know. I had people teach me that in a different way. But I think just being willing to do that. I think a lot of folks that come out in PT because of the academic rigor it takes to get in school, and then right, we all lived under if you make below an 80, you're getting kicked out. Don't see failure. Hey, my patient didn't get better. I've got a group of patients I need to improve on. Don't see that as an opportunity. See it as I failed, and it's a different way to think. And so I think that becomes important because if you're always learning and driving, then there's always opportunity on the other side, as opposed to if I failed, well, I'm awful, maybe I should go leave the profession. So it's a little heady, but I think really has allowed me to stay excited. It's allowed me to navigate and do a lot of different things in the profession that I'm very thankful to be able to do.
So that's phenomenal. Chuck, I want to thank you for engaging in this discussion. I feel as if I've gotten to know you a little bit and I've enjoyed every part of the discussion. Keep doing what you're doing. And I know you're in the middle of a lot of different aspects of this business. More
Thank you.
power to
I
you
appreciate the
as things
discussion,
go.
really enjoyed it, and thanks for having me.
Absolutely. You've been listening to Rehab Remix Reimagining Boundaries, produced by Band Connect. I'm Rohit Nayak, inviting you to join us next time as we continue our journey together in what we like to call our hybrid rehab revolution. Please join us, follow us, and subscribe to our channel. Thanks.